and Helen for giving me the opportunity to talk to you and our parents and carers and young people today. So, Gemma, if I can share my screen, so you can see my screen. So I work as a...
Oh, Prab, the screen's not come up yet. Let me see.
I will need to share, I think. You should see it now.
Lovely, thank you.
So I work as a consultant pediatric neurologist at Great Ormond Street Hospital, and I also run the headache clinic there along with my colleagues, Dr. Desai. We have an advanced nurse practitioner, Joe Mortimer, and a clinical nurse specialist as well. So we run our headache clinic along with our psychologists, and we see probably about 200 children, every new patient a year with a headache problem. And this clinic has been running for about, coming up to about 24 years now, and was started initially by a colleague of mine, Dr. Sarah Benton, and Professor Peter Goadsby, who is an adult neurologist and a headache specialist. And this clinic still, Professor Goadsby visits the clinic, and I run the clinic jointly with him on occasions. So a rich history, and what I'm going to talk today really is what I've heard and learned from young people and parents really over the years. And perhaps in the next half hour, I can share with you what I have accumulated over the years in terms of perhaps the something about the condition and how we can move forward with this. And I think, first of all, to say is actually, I'm so glad that I am giving the talk in 2021, because when I started this piece of work, 15, 20 years ago, there was very little I could offer my patients. But a lot has changed in the last 10 years, and it's been so exciting. So if you're a young migrainer, you're probably better off being a migrainer in 2021 compared to perhaps 10, 15 years ago, and I'll tell you why. Although there are options, I think the first thing a lot of my family members and kind of young people say is actually, why me? And, this kind of problem, how common is it? Actually, when we do scientific studies and go and survey people, about 2/3 of our childhood population have had at least one or more headache in the last year. And if you ask adolescents, so sort of teenagers, about 1% of them actually have a chronic daily headache. I mean, the numbers are huge. And this kind of numbers is sustained wherever you do the study, whether it's actually, in the UK or in India or in China or in Brazil. I think the numbers are the same. And in fact, the prevalence of migraine and headache in school-age children, a colleague of mine, Ishaq Abu Arafe and Russell, they did a study almost 3 decades ago in Scotland, and they showed actually the prevalence, as you can see, especially in teenage years, is actually quite high, about 23%. Okay, so that's about 1 in 5 teenager. When you go and surveillance study them, the prevalence is as high. It's not the same in all ages. As you can see, the younger age group, it's a little less. So on average, I find that in any classroom of 30, you will have at least one migraine. So that's actually how common it is. So some of the things, I guess, is what can I expect, or what you should demand really when you go see your doctor if you were to have a headache. Number first of all is actually they need to be able to recognize that this is actually migraine. And that's very important. Giving a positive diagnosis of this is migraine is important. And I'll talk to you a little bit about why that is important. And then, because migraine diagnosis is mostly about how the headache, the young person with the headache behaves, it's about the history. There is no test in the world which can tell you this person has migraine. So there is no investigations. So it is very important that the health professional who's making the diagnosis gets a good history, but doesn't do too many tests. I mean, because that some of those tests are not good for the body, and I think that will be important. And you can also expect that the management of migraine just doesn't involve just the doctor and a pill. Actually, it's a multidisciplinary effect. And again, we will allude to that later on in the talk. The key thing I have learned over the years, really, the best managed patient and a young person is actually when we empower the young person to take ownership of the condition and the management. And this we do over time. And I think, again, we will talk a little bit about that. And lastly, I think everyone who's involved in the care of young people, especially with headache, need to advocate for the child. And again, we'll talk a little bit about that. So, recognizing the condition, I think some of you probably in the audience might be actually surprised that actually 1 in 5 children, they will present before their school age, they start school. So that's how early migraine can actually start. That's because I think migraine comes in various forms. And in fact, there is now increasing evidence that actually colic, recurrent colic is probably a form of migraine. We always knew this. I think whenever I take a history, I always ask about colic. And usually I get asked, what this is all about. But I think this is how early things can actually start. There's a lot of children who will be colicky, but a considerable amount of them do turn out later in the age to have migraine, and the evidence now is accumulating that it's probably related. This is it's a condition, again, a rare condition. Again, there are some children where they will have a tilt to the head. This is an episodic tilt, not painful. They're otherwise happy, playful, and that's a form of an early migraine. This is a 2-year-old who has an episode where she would suddenly go into a room, appear very distressed, have a lot of vertigo or dizziness, and they would fall down. So this condition is called benign paroxysmal vertigo, and this is again a form of migraine. And children can also get what we call abdominal migraine, where they can end up having tummy pains, just sore, maybe in the center of the tummy. They might have a little bit of nausea, sometimes a bit of pallor, sometimes a bit of vomiting. And the attacks can last up to about 3 days and sometimes, and they're completely well in between. They're otherwise thriving and putting on weight and things. And this is a form of early migraine we see sometimes in children. We also see what is called a cyclical vomiting syndrome, and that can affect about 2% of children within the migraine population. These are highly stereotyped attacks of vomiting. And this vomiting is real in a sense that, there are multiple times, sometimes up to about 20, 30 times in a day. And some of them actually need hospitalization for treatment. So these syndromes, they start early. So the colic, as you know, in the infancy, the torticollis in the first year of life, and benign paroxysmal vertigo when they start to run around, abdominal migraine just in the preschool, school-age years, and cyclical vomiting and slightly in the older child. So, but of course, the typical migraine that adults would know of is the headache which comes on. But again, the headache that happens with migraine in children is actually a bit different. So some parents ask me, it's not like my migraine, because some parents actually have migraine themselves, and the child gets migraine and it's not the same. How can this migraine be a daily headache is another question I get often asked. How is it, completely well before, just had a cold or a bit of head injury and it all started? So, as I said to you before, I think one of the things which we really, really need to understand is that migraine diagnosis is mainly based on history. And as doctors, we are trained. This is the training I give to doctors. Whenever someone comes to us with a headache problem, we say we need to find out whether it is a primary headache, which is what migraine is, where we don't find any other reason for it, or a secondary headache where there is a cause for this headache. And in fact, if for the secondary headache, there are various types of reasons one can end up having a headache, including your head cold, your sinusitis, bleeding into the brain tumor, whatnot. I think so. So lots of reasons why someone might have a secondary headache. And doctors are taught how to get a history to differentiate between a primary and a secondary headache, and the physical examination to get to the bottom of why the headache is there. So there are some important differences between an adult having a migraine and a child having a migraine. So number one, in children, the attacks can actually be much shorter. So in adults, usually about 4 to 6 hours, maybe longer. In children, it can be short. It can actually be 2 hours, sometimes even less. And in adults, the pain is always sort of unilateral. That's part of the thing. But in children, the pain is almost always, they always get a kind of a headache. They go like this. And like an adult, they go like that. The child goes like that in young person. As they become teenagers, it becomes more unilateral. But in the younger age group, it's almost always a bilateral. And of course, the headache is pulsing in an adult, and in younger children, they can't really describe the pain. But it's important that we listen. And some children are able to draw the headache, and there's a very good way of getting the history out of the young person and how it actually feels. So making sure that they are able to describe what the pain feels like is also quite important. And one of the other features of migraine is actually the pain is severe. moderate to severe. So again, in children, if they're going to complain to you about a headache, it's usually something significant. The other features are with a migraine headache, any activity of daily activity gets your headache worse. And of course, for children and young people, it's any physical activity, including PE, sometimes can actually make things worse for them. And again, nausea, vomiting, photophobia, phonophobia, which is the light and sound sensitivity that you will see with the migraine attack. And in children and young people, sleep almost always helps the migraine. And there are some occasions where that might not be the case, but in the majority it does. So it's a colleague, David Koenig, who actually looked at what happens if children present to GP surgeries with a headache problem. And he found that actually 8 out of 10 do not get a diagnosis of what type of headache it is. So they don't get diagnosed with migraine. And after 2 out of 10 children where a diagnosis of migraine is made, only 4 out of 10 were offered any kind of treatment. So the recognition in primary care itself can be very low. So knowing about what to ask and be prepared is very important. I guess one of the biggest worries for parents and carers is actually, could this actually be something bad? And should my child actually have a brain scan or see a specialist? In fact, the majority of children who present, even to the emergency department, in the A&E department, again, these are studies which have shown that maybe about 5 to 20% might actually need some immediate action. And all of these conditions, they are able to diagnose based on clinical examination, not necessarily needing a scan. Again, when we look at children who are referred to a specialist headache clinic, most of them, the majority of them in my clinic, at least about 95% actually have migraine. And even there in the specialist clinic, a small proportion can have, we find out that they actually have something else. But again, important to assess that actually the 2 children in this particular study, out of the 850 children who ended up in this clinic, 2 had brain tumors, but the 2 also, the brain tumor was picked up not on the scan, but just on the history and clinical examination. So if someone is able to get a good history and a clinical examination, you can actually make a very positive diagnosis and also diagnose secondary headaches. So one of the things we have been doing to make sure pediatricians, GPs, everyone is actually able to diagnose and give a label is education. And we have developed courses for doctors and nurses to teach about migraine and headache disorders. And this is a kind of a summary slide I put in for those education meetings, saying if you knew what this slide was about, this slide kind of tells you what you need to know about headaches in general to make a positive diagnosis. And migraine is a major part of that. So a systematic approach to really getting a diagnosis is really about history, and more history. So just to give you a flavor, in my headache clinic, a new patient, if I were to see a new patient, the appointment is 1 hour. Obviously, your GP doesn't have this luxury. They have probably 7 minutes for an appointment. and your pediatrician probably about 20 minutes for 25 minutes for a new patient. So getting a history for them about the headache can actually be quite difficult, because you do need quite a lot of detail. But also knowing what details are needed for the consultation could also be quite helpful in terms of preparing for the consultation. And there is a very good document. Again, I will refer you to the Migraine Trust website. We'll ask Helen and Gemma at the end whether we still have it, about what questions you do need to ask your healthcare provider about the diagnosis and the management. So the history and the physical examination is the cornerstone of having a positive diagnosis. Where there remains, even after a good history and examination, a doubt, sometimes you have to bring the child back. Sometimes you have to ask you to keep a diary, a headache diary, for example, to document what these attacks are like. And again, you don't have to go overboard, but I think, simple things by using a kitchen calendar, just kind of marking the day when the child had a headache, and then marking whether you gave what sort of medication on there, and whether the child, the young person, had to miss school or not. So those are the three key things that you piece of information that you might need to take to a consultation. And of course, the features of the headache is something which the doctor or the healthcare professional can actually get at the consultation. There are some headaches where we call them, these are headaches where you need to really pay a bit more attention if your child has got any abnormal neurological examination. This is what the doctor is trying to assess when they are doing the examination. Some characteristics of some of the headaches. But again, in the majority of these will not be a secondary headache. And it's interestingly, if after doing a good history and an examination, the doctor is not able to say what type of headache it is, then that's also a headache where you need to pay a bit more attention. And in fact, this was again shown in a study. So part of the journey is about empowering. And part of that is actually knowing why does migraine occur, how it occurs, and when the problem does. So the way to think about it is actually migraine would be an inherited tendency. So by which I mean, 9 out of 10 children who come to my clinic have at least one first-degree relative who has got migraine. So it's got a strong genetic tendency to the condition. How and why it happens, I'll try and explain to you in the next few slides. So this is a cross-section of the brain. And this is a structure called thalamus, which senses the pain in the brain. And this part here, we would call that as brain stem. And the other interesting bit about the brain is actually the brain itself doesn't have any pain sensing structures. That's why this person is having brain surgery, but is not under anesthesia, because this person doesn't feel anything that's actually going on this, because there are no pain structures. So interestingly, all the pain that one feels around migraine actually comes from the covering of the brain, and the other structures that surrounds us, not from the brain itself. So there are a number of pain nerves and things which actually take the sensations from around it to the brain, and these nerve fibers will have to be activated somehow for the migraine pain to be sensed by the brain. I just put this picture just to kind of give you an idea about how many different types of enzymes and proteins there are, components involved in how pain is actually perceived within the nerve cell. These are the gap between the nerve cells, and these are the different types of compounds that are involved in sensing pain, or actually for the nerve to function properly. Which is complex, but also is quite interesting and brilliant, because in some ways you can manipulate a number of these compounds so that you can treat the pain. Okay, so we have many ways of how the pain can be treated. Although we have, and this kind of knowledge has actually only been possible in the last 20 odd years. And one of the compounds here, this called CGRP, and this is the latest one in town, where we have now identified a number of compounds which have now been used as a mechanism to treat migraine. So migraine, as such, I pointed to the brain stem there, and again, we know that's the area of interest, because that's an area where we know a lot of the migraine action actually happens. So if you were to take your child, young person wants to go to the doctor, this is a very kind of a smart phrase, as it were, to try and understand what are the information that your doctor or the health professional will want to know about your headache, so that they can find out what type of headache that you have and confirm the diagnosis and that it's actually migraine. So the mnemonic is liquid foe. Please don't ask who managed to make such a mnemonic, but anyway, it stands for location, where is the pain, what does the pain feel like, how bad is the pain, how long does the pain last for, how frequent are the attacks, are there any other symptoms like your vomiting, nausea, your light sensitivity, sound sensitivity, and what is the effect on the child, missing school and things. So this is a very good way of getting the history together. And we made strides. Now there is a nice guideline for young people and adults telling you about this. One kind of take home from today really would be pain. A lot of people would use over-the-counter medication to treat migraine and other headaches. But there is a condition called medication overuse headache, and especially if someone is actually having daily headaches, it's very easy for them to end up in the situation where they take any kind of painkillers more than 2 days a week, and these painkillers, and this includes very specific medication, including triptans. When you overuse them, that they themselves can give you headache. And this applies with children, and I have seen many young people in this. There is no role for codeine or any of those kind of compounds in the treatment of migraine. So that's something which I would never recommend, that if that's been prescribed, that's the wrong thing to do. So no cocodamol or any of those is needed for the treatment of migraine. As I said, I think we live in interesting times because we have better understanding of migraine and there is new therapies. But it always comes down to how we manage it in a multidisciplinary way. So I think the way I deal with this is to give a positive diagnosis, explain why migraine happens, reassure that some young people, especially, we've seen children as young as 7, where they have very significant migraine and they're completely terrified that something is happening to them, just reassuring them nothing bad will happen to them, and explaining the natural course of the condition, where we know that migraine can be very bad during teenage years, but usually it gets better in late teenage years, and it stays like that until in women you hit menopause, and in men in your late 50s, then you can have another small peak there. And I always explain to them that it's a migraine management. So actually it's a journey where they learn the skills, how to manage it, and I reassure them that we'll be there as a team to help them along the journey. There's a lot of education goes on in terms of lifestyle, how to identify the triggers and how to modify the triggers, dietary advice. And one thing I want to say about the diet really is that actually there's only 2 things for which there is good evidence that it will trigger a migraine. That's one is alcohol, which I hope none of your kids are into, and the other one is actually caffeine, and possibly nitrites that you find in cured meat. So I think there's no good evidence that chocolates and other things actually cause migraine, and this is another reason for it, and we can discuss this in the question and answer section. Sleep, obviously, very important, and school and attendance. We always have for children who are having very problem migraines, we have meetings with school and things to get things along, and goal setting for treatment and management is also very important. So the practical aspects, what you should expect is a clear written plan from your doctor saying, look, I've got a migraine, what do I need to do? Step 1, step 2. You need to make sure school is aware of the plan. School makes reasonable adjustments, quiet room, allowing access to water in the room. Sometimes you know that your migraine is coming on, you don't want each time to ask for permission to leave. Sometimes you just put your hand up or a special card, just get out of the classroom, go into a quiet room, take your medication. And again, access to medication in school settings, sometimes we have to facilitate that because schools won't allow a young person to carry medication with them. But again, we don't want them to be waiting for 20-30 minutes to get a medication from somewhere. So I think all of those can be facilitated. And again, for the young person, maintaining good physical health and emotional health is key to managing migraine. There are lots of medication. Basically, this slide tells you that all these medications work, So anything that's to the left of this line tells you that they actually work. And a combination of these can also be helpful. There are lots of licensed medications for young people, both in terms of prevention and for pain relief. But these are the exciting ones, that the CGRP, and some of these are actually now available for adults. We are now conducting trials in children in the UK, and these will be available soon. We also have the possibility of neuromodulation. So for migraine and for problem migraines, all of these, including nerve blocks, Botox, nerve implants, and all of these are available, but the majority won't need these things. And of course, we shouldn't forget about the nutraceuticals, by which I mean there are vitamins that can actually be quite helpful. We know there's acupuncture is helpful, and so is cognitive behavioral therapy, relaxation. There's some evidence for osteopathy, but no evidence for homeopathy. So that's the migraine management. I think I'm about 5 minutes over my time. And this last slide is really to tell you, if you were to Google International Headache Society and classification, you will get to a web page, and in there they have a total of 72 different types of primary headaches and 141 different types of secondary headaches. So that's how many different types of headache there are. But the commonest one that gives the most disability is actually migraine. Okay, and that can be quite debilitating. I'm going to end there. Thank you.
Lovely, thank you, Prab. That was very useful. So we are going to go into a recording from Dr. Harvey because she was unable to be here today. I can see some questions coming in, so we'll go through those in the question and answer session, so do please keep popping them in. But I will share my screen and hopefully we will be able to see Dr. Harvey's presentation. So, fingers crossed.
Hello, my name is Dr. Rebecca Harvey. I'm a clinical psychologist at Great Ormond Street Hospital. First of all, I'd like to say thank you to my colleague, Dr. Prabhakar, for his presentation this morning. So today I am going to speak to you about migraine in children and the role of psychology. So I'm just going to share my screen with you now. The role of psychology in managing migraine in children and young people. So the first thing to think about is, why is there a psychologist involved in the headache service, or why would a psychologist be useful for helping a child or young person manage migraine or a headache, another headache condition? The first thing to speak about is, and to acknowledge, is to recognise, I suppose, the wider impact of living with a chronic condition such as headache or migraine. And that covers kind of emotional, social, behavioural and educational factors. So, for example, coping with the challenging symptoms themselves and their frequency, which can impact on missing school, falling behind in school and then having to catch up. Also socially withdrawing, doing less of what the young person enjoys, and having a bit of a boom and bust cycle, an approach to activities where the young person might feel very good on one day because they're not experiencing migraine or headache, but on the next day they are wiped out because they've pushed themselves too much on the good day. Also, not seeing friends. We know how important friends are to children and young people, and feeling different to everybody else in maybe in their school or their social life, or even their family, as perhaps they don't have a headache condition either. So, of course, all these factors can lead to a lot of stress and anxiety, frustration, sadness, which compound and can exacerbate the migraine. Also, it's important to recognise the impact of these factors in terms of triggers. So, for example, sleeping, a disrupted sleep routine, sleeping too much or too little, stress that's related to school, or even any emotional state such as excitement. If there's a party or a family event that the child or young person is looking forward to, this might have an impact. The headache might have be brought on by the excitement, and then they may end up having to miss the event. And so, of course, we can appreciate the impact this might have on peer relationships. And of course, there is evidence for the effectiveness of psychological approaches in treating and managing migraine and headache conditions. So firstly, cognitive behavioural therapy, or CBT, is something some of you might have heard of before. So there's quite a lot of evidence that CBT can help manage chronic pain, for example, like a migraine condition, and also relaxation techniques have been shown to help manage migraine. So it's important to talk about some myths around psychology in the headache service, and what psychology in the headache service isn't. So by involving a psychologist, we're not saying that it's all in the young person's head. Of course, we recognise the reality of the symptoms. Also, psychology is not for the treatment of mental health problems as well. And that point is mainly about the focus of the treatment being on the headache condition and the impact of the headache condition, rather than the focus being mainly on mental health factors, other mental health factors being the primary cause. And third, having a psychologist involved doesn't mean that the team or the health team see that psychological factors are the initial cause of the symptoms. Of course, we recognise there is a medical cause for the headache condition, but of course, psychologically, there may be, and psychologically, socially as well, there's an important contributing factor in relation to the triggers that I've just spoken about in the previous slide, often leading to an exacerbation of the headache condition. Now I'm going to show you a typical psychological formulation, which is something that we may create and develop in conjunction with a child or young person to help them make more sense of their difficulties. So we start off here having a look at or asking the child about the family history of headache or other health conditions. Then we'd ask them to kind of pinpoint any triggers they have in their environment. It could be eating certain foods, drinking, could be sleep or lack of sleep, could be something to do with light and noise in their environment. Also activity, physical exertion could be a real trigger for the young person, and stress itself. And here we can see, these predisposing factors and the triggers have led to a vicious cycle of the headache condition. And as I mentioned before, psychology just uses a biopsychosocial model. So that means looking at the physical side, so the biology, the medical side of the actual symptoms, also the social aspects as well. So here we can see in this vicious cycle for this person, their headaches have been triggered, causing these physical symptoms. So not just headache, but also we recognise the stomach ache, perhaps nausea, dizziness, some tension maybe, and disrupted sleep. And of course, there's a long list of different symptoms that might come under this in this box. And of course, this can, having these symptoms can lead to the child experiencing difficult thoughts about their condition. So I can't do anything, I can't cope, it's going to get worse. If I do that, I will get a headache. So if I do a certain activity, I'll get a headache, or nobody understands me and I'm going to miss out. So of course we can see that this would cause some very difficult emotions to come up for them. So it's not surprising if they're having those kind of thoughts that they're feeling worried, anxious, sad, frustrated and stressed. So this is why we have arrows between the boxes, because we appreciate in CBT that thoughts, physical symptoms, emotions, behaviours are all connected to each other and can impact each other. So considering that this child in this example here is experiencing physical symptoms, difficult thoughts and emotions, it can lead them to take certain actions, for example, missing school because they're so worried about attending, falling behind in their schoolwork because they've missed it, withdrawing from their friends because they feel like they're missing out, sleeping during the day because they're not able to sleep at night, and generally maybe some actions related to activities, so doing less and less, avoiding or doing too much on good days. And here we've got some external factors, so considering the family, school, friends, health services. So we developed this formulation, as I said, with the child, and then use this to direct our intervention to see where in this cycle, where can we break this vicious cycle? And usually it's about challenging these difficult thoughts. So is it really that you can't do anything, or is there a more kind of balanced alternative thought that yes, there are some days where your functioning is very limited, but other days you are able to do something. Also, we might challenge or suggest a different way to behave. So, for example, not missing school, trying to attend, even if there's a phased return to school. Encouraging the young person to see their friends. When they can, but maybe it will look a little bit different to how they might have socialised before their headache, the onset of their migraine condition. So the focus of a psychological intervention for migraine would be to reduce the impact that the symptoms are having, to recognise the difficult cycles on the previous page. So I think that sometimes half the battle is actually becoming aware that the child or young person is getting into these vicious cycles in the first place. Then third, developing new strategies. So this is where we bring in perhaps different psychological interventions that have an evidence base, and so they've been shown to have worked previously. So managing known triggers. And number 5, improving functioning. So that's working towards doing more of what matters to the young person. And I'm going to talk about that a little bit more now. So what do we mean by functioning? Well, what we mean is being able to do things that matter to you. So whether that be being able to engage in football practice or gymnastics, or simply socialising with friends, perhaps going to school and achieving the grades that you want to. And so it's very individual for each child. And why is it important? So it's part of what we would consider a good outcome. So of course, a good outcome for a psychological intervention would be a reduction in the frequency and or the intensity of the migraines themselves, of course, but also, you know, if there was an improvement in functioning, or the child is able to do more of what is really important to them, we'd expect to see an improvement in their mood and a reduction in the amount of stress that they're experiencing. But what we need to recognise is that it's not a cure or a complete freedom from the symptoms. This condition is often chronic. Well, it is chronic, and that's why they've got the diagnosis. So we need to appreciate that it may take time to achieve these outcomes, and they're not always achievable for everyone. But whatever the outcome is, it's really important that the young person is supported to continue moving towards living the life they want to lead. The focus is on doing this now, wherever you are in your journey, not stopping and waiting for a reduction in symptoms, but trying to manage the symptoms that you have now. So we know that this is achievable, even if the young person is experiencing continued symptoms. But the reality is life might look different than it did before. So some examples are doing the same activity but less. So for example, at school, having a reduced timetable or a reduced number of subjects, so that their efforts can be focused on the subjects that are really important for them, or the subjects that they need to get to college or university. Also, adapting the activity can be helpful. So spending time with friends at home rather than going somewhere with lots of background noise. So trying to, for example, I suppose adapt the environment, but you're still spending time socialising. There's also room to try and gradually build back to something you've stopped doing. So if it's exercise, beginning by doing the exercise for a much shorter amount of time and then gradually increasing. Or doing an activity that's different, a different activity, but it's kind of related to an old activity. So, for example, playing an instrument at home for enjoyment rather than working towards a formal grade. So what are some possible barriers to trying to improve functioning? One is suppose, shared ideas about illnesses. So, for example, if you're experiencing symptoms, you should stop and rest and wait to get better. So this is something that works really well for acute, short-term symptoms like a cold or a flu, or even kind of breaking a bone. It makes sense to stop and rest and get better, but it doesn't work so well for long-term conditions like migraine, of course, because the symptoms are there, and we might try our best to manage those symptoms with medication, but if they're still present and the child or young person stops doing things, it can really impact their emotional well-being, their self-esteem, if they're not achieving what they could before. And less activity can lead to reduced stamina in itself. So we need a different approach here by adapting and not stopping. So this is something that could help, making sure that the goals you set yourself are realistic, identifying the first step and recognising the achievement in reaching this. So actually working with those around you to agree plans and then stick to them. And I'll talk about this a little bit more in a minute, but it is important to, I suppose, get school on board, parents, friends, or other organisations. So it's perhaps about speaking to the school or parents or friends about the headache condition, or your migraine, and I suppose setting their expectations about what you're able to do. Also recognising other factors that may be getting in the way of accessing help. So, for example, anxiety or low mood, you may be just not feeling motivated to access help, and it can be, of course, we recognise that it can be very difficult to ask for help. Just to give you an idea of what activities are associated with well-being, and it's the same for people suffering with a chronic health condition like migraine. So connecting with others, socialising in whatever way you like to, whether that's with lots of people or perhaps a small group or even one person. And I suppose the connecting can be in lots of different ways. It may not always be meeting up face to face, but speaking on the phone, or even playing a game online with your friends. Giving to others and having a positive influence. So that makes me think of volunteering, or it could be simpler than that. Can be as simple as kind of making someone a cup of tea or opening the door for them. But helping or giving to others has been shown to be to boost mood. Being active, of course, exercising. I'm sure you've all heard of the endorphins that exercise and being active, and even gentle exercise can bring on a rush of endorphins that are going to boost mood. Also embracing the moment. We can often be on automatic pilot when we've got lots of things in our mind. So trying to be in the present moment by either practicing mindfulness or simply taking a step back and noticing, maybe using all your senses in that moment to notice where you are, what you're doing, whether that be eating, walking, or for parents, driving, or even, I suppose, young people, some of our older young people. Challenging ourselves and learning, and this is where school comes in, and the importance of attending school or trying to attend school as much as you can is hugely important. And caring for ourselves in whatever way that is helpful to you. And so that could be having a nice bath for some people, or listening to some relaxing music. Other people may want to do something a bit more active, like going for a run, and that's when they're feeling better. So a word about school. It's very important to mention this. So our view at Great Ormond Street is that attending school is a really important part of children and young people's lives in terms of working towards their long-term goals, and developing social skills and life skills that they need in the future. So we'd always encourage as much as the young person and child can to attend as much school as possible. Obviously with COVID it hasn't been so easy, and schools have adapted to homeschooling, but now they're mostly all back. Of course, we would continue to encourage that the child and young person attends school or sixth form or college. At Great Ormond Street, we can work with schools to develop a plan for returning, or a plan for at least increasing attendance. It's just important to mention that we really don't recommend being out of school for the long term because of headache or migraine conditions. It's all about, as I've said before, trying to manage symptoms, manage these chronic symptoms in order to still be able to access education and other parts of life that are important to the child and young person. So this is just an example of some of the things that we include in a plan for school, and getting someone back to school. So a reduced timetable for school time in school to include breaks, but perhaps possibly more breaks than are in the timetable at the moment. A reduced number of subjects, so just, I suppose, taking the core subjects at either GCSE or perhaps dropping an A level, to help the young person manage their workload. Having one point of contact to coordinate any missed work and deadlines is really important, so that the child or young person knows who they can go to in order to catch up. Having a medical pass or timeout pass can work really well. If the young person needs to leave the classroom, they can show their card and no questions are asked, and they can leave discreetly. Having somewhere quiet to work or a quiet room during migraine attacks can be really helpful. Of course, having quick access to medication is very important for managing those symptoms, and generally helping to overcome barriers. So helping the young person with managing their stress and anxiety, and that might be about giving them access to a school counsellor or somebody like that they can go to when they are feeling stressed and anxious. So a word about other services that can help with migraine when the migraine presents with other issues such as anxiety, low mood. They're very common in children and young people with health conditions. They're more likely to experience mental health difficulties, and as we know, 1 in 3 people do experience a mental health difficulty in their life. They're very common in the general population, and even more so in young people with health conditions. The Child and Adolescent Mental Health Service, so CAMS, can offer interventions which are shown to be effective in helping to manage mental health and emotional well-being. So many young people will need to access, or can find it a benefit to access, these types of services, local services, as well as perhaps their health team and GP, in order to manage their symptoms well. So referrals are usually made by a health professional, for example, a GP, a paediatrician, or of course, GOSH, we do refer a lot of our children to the local CAMS service and then work with them. But what can you do now? So, of course, there are other things that you can do. There's a range of useful websites that can offer advice on lots of different things, like sleep management, pacing and planning, becoming aware of your thoughts, negative thoughts, and then how to manage them. So there's lots of information out there, and I will send a list of useful links to our organisers so that you can have a look for yourself. And we've just got a couple of common questions here. I think there's a couple of minutes for questions, and I'll make it quick because I know I'm probably running out of time. So these are common questions that come up from other presentations that I've done. So the first one is, what do I do if my school does not see my headache condition as serious? And this is sometimes a common complaint, especially in schools where staff turnover is high, so that the new staff members are unaware of the child's headache condition. And they might even minimise it as a kind of common headache, you know, or where they're expecting the child to be able to carry on with the lesson. So, of course, a liaison with a health team, maybe CAMS or the GP and the school, is important to make them aware of the chronic nature of the migraine condition. So something that could work quite well is that you could request for CAMS or the GP to send a formal letter which outlines the child's condition as chronic. And it also may be helpful to organise a professionals meeting with the school and the specialist services involved, inviting yourselves as parents, and maybe even the child or young person themselves, depending on their age, and whether they feel comfortable at a meeting like that. The second common question is, do I have to see a psychologist if I have a headache condition? And of course not. That no one would force a child or young person or parent to see a psychologist if they don't want to. So a psychologist would want consent from the child, and to know that they want to do the therapy. Otherwise, it's very difficult to build a therapeutic relationship if the child has little motivation or wish to engage in the therapy. Or the other option is that it might not be necessary to involve a psychologist. It isn't always, as I've said, there's lots of self-help strategies that are widely available for children and young people and parents, and they can help improve kind of psychological symptoms and factors without the need to actually see a psychologist. And as I've said, I will sent organisers a list of good self-help materials that you can access.
The vitamins, and which ones are recommended and in what doses?
So in terms of vitamins, I think there is good evidence for, the best evidence in children is for riboflavin, which is a B vitamin B2. And the trials were conducted at a dose of about 400 milligrams a day. And you will need probably trial it for a good 3 months. And most of the time, for younger patients, we kind of would probably suggest something like 200 milligrams a day. So pre-pubertal children, I think about 200 milligrams a day. And for older teenagers, I think 400 milligrams a day.
Lovely. And someone specifically asked about magnesium as well.
Yeah. So the trial recommendations for magnesium, the doses that is actually required for good migraine prophylaxis usually lead to side effects. And magnesium side effects, as you know, milk of magnesia, it's used for constipation. So I think diarrhea can be a problem, but you know, doses up to about 500 milligrams a day would be needed for it to be effective.
Lovely, thank you.
And I think the third vitamin is actually coenzyme Q10. And I think, again, doses between 100 to 200 milligrams a day is being used in trials again. Now, in children, I think, in our experience, I think riboflavin, we found it to be helpful. And some of our patients have actually found combination medications. I think they've sourced from other European countries, I think, which is available, which has got all the different ingredients, but not at the same doses that are recommended. Usually with the combination medications, I find that actually the doses are not like what we would recommend. So if you were to try those vitamins, then again, I always recommend it, do one at a time. And 400 milligrams. So someone's asked whether 400 grams of vitamin, but it's milligrams of vitamin B2 is enough. Yeah.
Brilliant, thank you. And then quite a lot of questions around Migraleave and codeine. So one is, why isn't codeine recommended? And two is whether Migraleave is okay to take because GPs have been recommending it.
Yeah. So I think it's interesting. I think so in this country, in order to become a GP, you do medical school, but there is no compulsion for you to actually do any pediatrics. You can become a GP without doing any training in pediatrics. So a lot of GPs do not have necessarily know the doses and things that are required. And I think Migraleave is initially for adults. And again, even an adult recommendation now is actually not to use codeine, because all the studies are that if you use codeine in the treatment of pain, especially in migraine, there is a tendency for the migraine to become chronic, and then the migraine also becomes difficult to treat. In fact, chronic codeine usage and opioid usage of any kind, it actually changes some of the pain pathways in the brain. So you can actually now do scans of the brain and actually show that there are physical changes in the brain due to codeine. So I think there are medications like your paracetamol, ibuprofen, and others, including the triptans, which we have used for treatment of acute relief of migraine. And now we also have the dietins and the CGRP molecules coming in. So I think there are better ones than codeine available to treat migraine.
Lovely. And then I suppose building onto that, there's some questions around preventive treatment. So one is there any benefit to taking preventive treatment? Because a neurologist has said there isn't. And others are around if a child is on a preventive, should they be followed up regularly? And also, how do you get onto a preventive?
So the decision to whether the child needs a preventive medicine or not, it depends upon how frequent are the attacks and how long the attacks are. So it might very well be that there are only, say, 2-3 attacks in a month. But if the attacks are lasting 3 days for some, I just saw one member actually saying that there are 3-day attacks. So that's actually pretty much 12 days in a month of the child's life gone. So that actually, in my books, will need treatment in terms of preventive. So it's not about just the frequency, but actually the length of the attacks and the severity of the attacks. Some attacks actually, they don't keep anything. They actually get dehydrated. They end up in hospital. So those attacks. So it's a combination of things that makes you decide which one needs treatment. And the second bit actually is, what is it we are treating? And that becomes very important. This is where I alluded to the goal setting. So one of the myths about all these preventive treatments is actually when we do research trials, what the trials are doing, the outcome we are looking for is for the attacks to go down by 50% or less. So when a drug comes out in the market and says, yes, this is a migraine treatment, what they are saying is actually this: if you take this drug, the migraine attacks will go down by 50% or less. It doesn't cure your migraine. It doesn't stop them. Yes, in a small proportion or about 10%, it can actually give quite significant migraine relief. But I think the end point for these trials are 50% or less. So I think that dialogue needs to be very clear with that young person and the family, that if you are having about 4 attacks in a month, you take this medication, and then this will actually make your headaches 2 or less, because that will be the outcome that the minimum outcome that you're aiming for. And some of these medications, the preventive medications, you need to give it a good 3 months to actually know whether these medications are effective. And unfortunately, the current ones which are available for use in the pediatric population, if the medications give you side effect, they will come first. Okay. So usually you will find that as soon as you start taking the medication, if they were to give you side effects, you will see them within 2-3 weeks. In the first 6 weeks, you will see that. And in the majority, if you don't warn and tell them about the side effects, you're going to stop those preventive treatments, because sometimes the child or the young person doesn't, they can't tolerate the side effects. But if they did, then most of the side effects do go away, and the beneficial effects of the preventive medication will be seen from about week 8 to 12. So I think all of this is very important before one considers starting someone on preventive medicine.
Lovely, thank you. And then there was a question around the Kefali device and whether that's recommended.
Yes, we have used Kefali. There is some evidence that in some selected patients, it can be helpful. And again, it's like anything else. It's about making sure for that particular young person, it's actually something that they will tolerate, because it does give you a bit of a a buzzing kind of discomfort. And for some, they cannot tolerate that discomfort, because for some migraineurs, you get what is called allodynia, which is, you just touch it, the skin becomes very sensitive. So those patients won't tolerate the carefully device. So I think it's also about making sure you select the right patient to use those devices.
Lovely. And then quite a lot of comments around schools and education, and a good comment about, for some people, it's about access to education, not necessarily access to a physical building, to the school building, but also lots of issues, it seems to be, with schools not recognising migraine as a condition, and how to support children at school, particularly during exams and I suppose periods of stress.
Yeah, I guess, we've done quite a lot of work about school. So one thing is very clear. For some of our patients, accessing education and actually being in a physical building and travel can actually be very difficult. But equally, being around peers is also very important part of growing and someone's emotional and other well-being, really. So it is a balance of accessing education plus the other aspects of education, which is about being with peers. So it's a delicate balance, and I think schools, yes, most of them do respond when approached and given the right amount of information. There is a very good document from the Royal College of General for GPs, which again, David Kendrick, one of the doctors I was talking to about, he has put together. It's easily available. If you just Google migraine and schools and RCGP, it will come up. It's got some recommendations. And again, I know that Helen, for example, here within the Migraine Trust has advocated with schools in terms of accessing and what they can do in terms of provisions. Yes, advocacy very important, but also getting a very clear written plan from your doctor about what needs to be done will also be quite helpful in terms of accessing the provisions in school.
Lovely. And then a few questions around hemiplegic migraine. So one is whether a child with hemiplegic migraine age 6 should be offered CBT.
Hemiplegic migraine is it's a special type of migraine where children and people can, it's almost like, they behave like someone who's had a stroke. So they lose the ability to move their arm or leg, or sometimes the face falls, like it's almost like a stroke. They can affect just one part or sometimes all 4 limbs. And it can be quite scary for the child. For that reason, I think alone, I think it will be very important that they do get some psychology in terms of counseling to talk through the attacks. And in terms of CBT, the other thing about hemiplegic migraine is actually it's a special type of migraine, but these children can also have, what we classically would call migraine without the weakness attacks. So definitely those will respond to things like CBT.
Yeah, and I suppose something around how you access CBT if you're not under a specialist headache clinic who has it on site, I suppose.
Yeah, I think as is well documented in the national media, accessing mental health resource for children especially is a postcode lottery, where it's not high on the radar. We've been doing quite a lot of work trying trying to recognize, and especially in the last 18 months with the pandemic, the need for psychological services, especially for things like CBC and teaching techniques for relaxation, actually been extremely relevant and important in managing migraine and other emotional and mental health disorders in young people. There are some online resources available, but again, for younger children, it can actually be quite difficult. One way to do that might be, I'm aware, so in London, apart from Great Ormond Street, I think there is also headache clinic south of the river at the Evelina Children's. So one option might actually be to get a referral to the specialist headache clinics through your pediatrician, but also the CAMS team, local CAMS team, can also refer for these groups. What we are planning to do, provided we find the resources, to join up with organizations like Migraine Trust. So we've been talking with our psychologists to see whether we can run group sessions through the charities, to see whether for young people especially, because it's an area of unmet need, and we need to try and plug that.
Lovely. And any medication available to help with hemiplegic migraine?
Yes, for hemiplegic migraine, especially if that is the diagnosis you've been given, I would recommend that your child is definitely under a specialist headache clinic, and it's not it's a very rare type of migraine, and it has to be under there are some specialist medications that can be used, but it's only on a named patient basis. So I would suggest that a referral to a migraine specialist or a specialist headache clinic is sought, really.
Lovely, thank you. And a question around COVID and hemiplegic migraine, but I think it probably relates to migraine generally, and that's it. Should people be concerned about migraine and COVID, and could COVID cause an increase in migraine attacks?
Yeah. So I think we have seen both, really. So when the pandemic started, I think when the schools all shut, I think there was definitely, this is from our patients, that when the school, the early part of the pandemic, that stress from school kind of went away, and there was a period of time when their migraines actually did, the frequency of the migraine attacks did go down. But then when they actually had increasing dithering about how the GCSEs was going to be marked, we actually got more phone calls about more migraine. So I think definitely in terms of well-being, emotional well-being, and that can be tracked right through the pandemic as to the young people's mental health and emotional health. It just took off, and migraine frequency and attacks also started to go up. So that's the pattern of the trend we are seeing. So COVID definitely has had an impact on young migraineurs in terms of making them having more migraine, really.
Thank you. And lots of questions around vertigo, dizziness, nausea, sickness, and severe aura. And if you've got any sort of practical tips and advice for treatments on managing those symptoms.
Again, I think auras can be very, very many. The commonest in children, as in adults, will actually be visual aura. But things like vertigo can be coexistent with other conditions, and it can be quite debilitating for young people in terms of functioning. We in our practice, I think if for example, vertigo, if that was a persistent vertigo, again, we would expect that to be assessed by a audiovestibular physician, and then there are some specific exercises to help with the balance structures of the inner ear. So I think there are some very specific things that can be done to address persistent symptoms, especially in terms of vertigo. So I think, yes, I think it's just recognizing the auras. And again, when it comes to aura, not all aura are the same. And there are also other medical conditions that can mimic aura. So again, making sure that one actually has a good and thorough assessment and understanding of that is also equally important.
Great. And how long should a vestibular migraine attack last?
So the term vestibular migraine is the way to think about migraine is this. Migraine is a brain condition. You need to have the genetic tendency to have migraine. So you have some genes that put you at risk of or getting migraine. And then you have triggers that will trigger migraine. That could be your weather, that could be your travel, that could be your, so there could be a number of different triggers. And the way that migraine manifests in terms of symptoms is actually what we call this gating mechanism. So when you're in the middle of a migraine attack, you have this light sensitivity and sound sensitivity. It's not suddenly someone has gone up to the sky and kind of turned the sun has suddenly become bright, or the light has suddenly become bright. It's just the same source, but the brain perceives when you're in the middle of a migraine attack for it to be bright. The same thing happens when in terms of vestibular symptoms. Vestibule, inner ear, so that can actually be balance structures, and that's your vertigo. So it's not that you feel that you are spinning, or the room is spinning, or you're being off balance, because there are structures within your inner ear, they are like very fine hairs which actually move, and there is a fluid within the inner ear, and these minute hairs which actually move within the inner ear in the fluid, that's how they sense what the position of where the body is. Now, all of these information is being fed back to the brain. And you can imagine that if the brain is perceiving the light to be bright, any of these movements is also sensed as a sense of spinning and vertigo. So it's actually migraine with a slightly different bit of what we classify as the vestibular symptoms actually being more. So like migraine, you can actually end up having a chronic migraine. So these symptoms can be persistent. So in theory, you could end up having a persistent attack in terms of vestibular migraine.
Thank you. And then we've had a few questions about abdominal migraine in terms of the treatments recommended to relieve it. And also someone said that their daughter has developed a tic disorder that started around the same time they started taking propranolol for abdominal migraine, and whether there would be a link.
So abdominal migraines, although well recognized, the majority of young people will respond to just simple analgesia. They won't need any preventives. So they get the odd sort of tummy ache, central abdominal pain now and then. Usually it's put down to, yes, you're just putting it on because you don't want to go to school kind of thing, because that's the kind of age it usually starts. But over time, it becomes very clear these are very central abdominal pain. the child has a bit of nausea, goes a bit pale. And in the majority of the time, just paracetamol and ibuprofen will be all that is required, and the reassurance that this is actually abdominal migraine. And so making a positive diagnosis is key. In some, the attacks can be a bit longer, more frequent, in which case you do need preventives. And it's unfortunately one of those areas where the preventives are, the preventives that has been studied in abdominal migraine have not been shown to be that effective. So people tend to use things like bisotifen or propanol or topiramate in some. And topiramate, as you know, propanol is a blood pressure medicine which is used in the treatment of migraine. Topiramate is a anti-seizure medicine, which is again has been used and documented to show very good effect in migraine as well. So as regards propanol and tics, interestingly, propanol is actually used to manage tic disorders as well. Whether I haven't seen propanol causing tics as a side effect, but I'm sure if you looked at the BNF, it's probably one of the long list of things that could probably happen. Propanol, the common side effects of propanol will be your nightmares. So some children actually can get very vivid dreams at night. It can also make you feel a little bit tired. And of course, those two probably are the most common side effects I tend to see with propanol.
Thank you. And then a couple of questions around, prognosis and the likelihood of growing out of migraine in boys and girls.
Yeah. So I think we have used this growing out of terminology for decades. My way of looking at it is actually you have migraine, and the migraine is a condition which is lifelong. For some, it starts in childhood and has a horrible time, and then the tendency is for it to sort of decrease in the intensity and frequency of the attacks. So by the time sort of late teenage years, it starts to go down, and it remains like that until probably late 50s. So yes, the majority of the children's, the attack do go down. By the time they finished your A-levels and gone to uni, they've got other things to worry about, I think, and migraine becomes less of an issue for the majority of young people.
Lovely. And some stuff around anti-sickness medication and managing nausea and vomiting, or so I think someone's asked about travel.
Yeah. So travel sickness can be things that you can get off the shelf in terms of hyoscine or prochlorperazine, Berythal. Both can be used for travel sickness, and they also are anti-nausea medications. I mean, we used to have a few which have now been taken off the market. So things like domperidone used to be used, but it's now not used anymore. Things like metoclopramide has been used as and can be used as a anti-nausea medication. We've also used things like ondansetron. But the problem with the nausea is that, if you're sick, how can you keep things down? So sometimes we have to find suppository versions of these medications for the young person to take. So I think, yeah.
And just on that point, someone said that their son's just been prescribed domperidone, so should they not be taking it?
I think the MHRA, sometimes domperidone can give you sort of prolonged QT intervals and things. So they should just be monitored. If they are taking, your GP or your pediatrician should be monitoring things. So just check with your doctor.
Lovely. I'm slightly mindful of the time, so I'll try and get through a few more questions. If we don't get a chance to answer them, you can contact the Migraine Trust helpline. I'll put the details in the chat box, or Helen can pop the details in the chat box. So if you do have questions, you can contact us. But I'll try and get through a few more before we wrap up. So there's a couple of questions around triptans. So one is that their son was prescribed a sumatriptan, half a tablet, and then increased to a tablet, but no one can give them any information on what a maximum number of doses would be. Just they're warned not to take too many. So can you say sort of how many tablets per month is acceptable?
So I guess the general rule I kind of say to my patients, you stick to the 2-day rule. So the 2-day rule is that you can take any painkiller, any triptan, not more than 2 days in a week. So one option might be you take Monday and Tuesday a triptan, Wednesday, Thursday your paracetamol, and Friday, Saturday your ibuprofen, and give Sunday a rest. And then you will not end up in the problem with medication overuse. So the 2-day rule. And then the other thing is actually, if you take the triptans, you can repeat the triptan within 2 hours of taking the first dose, but not more for the same migraine. So if you have a migraine which lasts for 3 days, it's very unlikely, if your triptan hasn't worked on day 1, to actually work on day 2 and day 3. So you will find that in your experience that actually if it didn't work, because by the time the migraine has actually started, most of the time the horse has bolted the stable, really, usually. So the trick, again, that is one of the reasons why we emphasize that these acute treatments and the triptans should be taken as early as possible in the attack to have the maximum impact on the particular attack. So yes, you can take it up to two times in a week maximum. That would be the recommendation.
Lovely. And someone's asked about nasal triptans as an option because their son's migraines happen in the early hours and they have a few minutes to get the triptan before they start vomiting. So is nasal triptan an option?
Yeah, so I think intranasal sumatriptan and zolmitriptan come as sprays, and they can be used in young people.
Lovely. And then someone said that their child started suffering from chronic migraines following a stroke. Is that common in young people who've experienced a stroke? And are there any sources of advice?
I think, as with any kind of intracranial problems, a stroke can be a trigger for migraine. So can things like meningitis, encephalitis, so infections and things like that. They can. If it is following a stroke, then some are put on things like aspirin for life. So, if you're on aspirin, you can't really take ibuprofen. So I think so you're left with paracetamol. There isn't a absolute contraindication for triptans, but again, depending upon why the child ended up having a stroke, there might be some special recommendations. There are, the anti-migraine preventive treatments can also be used for someone with post-stroke in terms of migraine. And again, if you have both of that, again, it's very likely your child is already under a neurologist, but they should seek some advice from a specialist as well.
Lovely. And I suppose just one last point around how someone would go to getting to a specialist headache clinic and what the process is, I think is useful.
So the process, I think for us, you will need your pediatrician to refer. We don't take GP referrals. just because we don't have the capacity. So we expect the pediatrician to have either made a diagnosis, tried at least 2 anti-migraine treatments, and made an effort to do that. And if they fail that, then we would take a referral in our headache clinic. And these criteria will be different in other centers, but in the majority I'm aware of within London, they will need a pediatrician to make that referral into a specialist headache clinic. And there are also some pediatricians who run specialist headache clinic, and we know that there is one in Queen's Hospital, Romford, where a pediatrician does a specialist headache clinic. So I think there are pockets of places within London that there are specialist headache clinics, and we are trying to train more pediatricians to be doing more of headache. And some of the pediatricians have. We are training them at Great Ormond Street to do more of headache, so that they can be delivered much more closer to home.
Lovely, thank you, Dr. Prabhakar, and thank you very much for your presentation and your time, and thanks to Dr. Harvey as well.